Good morning, everyone. And today, this is the first lecture of rehabilitation by me. And first of all, though the introduction of rehabilitation medicine is done already, but I would like to talk a little about that first and then talk about some basics. And later on, I'm going to talk about some of the conditions in which rehabilitation medicine plays role. So basically, this is called as physical medicine and rehabilitation. Uh, the full name, this is the name, by the way, which is used in different countries, and the people who work in this are called as this is also called as physiatry. And what is this specialty? It is basically a specialty that involves restoring the functions for a person who has been disabled as a result of disease, as a result of disorder, or as a result of injury. So, simply, when someone have any disease like stroke, for example, any injury like sports injuries, or any injury which basically is limiting the person ability uh, to survive in the society, or it is putting some limitation on his um, daily activities, for example. So like this medicine, it try to restore as much as can be restored. So of course, it is not about just physical restoration, rather it is physical, emotional, medical, vocational, and the social needs as well. And the doctor who works in this field is called as physiatrist. Okay, so uh, this is the basic baseline or basics about this thing. So now we are going to cover rehabilitation, right? uh, I have to give you exactly what you can say around 6 hours of lectures, and I have decided to talk about stroke. I've decided to talk about um, diseases like rheumatoid arthritis, or not just stroke, like rather TBI, traumatic brain injury, also spinal cord problems, uh, some of the diseases in which like neuromuscular problems, sports injuries, cancers, um, pulmonary rehabilitation, cardiac rehabilitation, and things like this. So now, basically, the main aim is to rehabilitate the person. So as we know, like what is rehabilitation? It is a process uh, by which we can help anyone, or in this case, a patient, to achieve the highest level of function, so that he can be as much independent as he can, and of course that will improve the quality of his life. So of course, like some of the functions can be brought back, but some of the damages are irreversible, some of the injuries are, you can say, irreparable. So of course, rehabilitation is going to make or try to treat the things. Okay, so there are, by the way, many basic same. For example, one of the aim is to treat the disease and prevent the complications, or one of the thing is to treat the disability and improve the function. Sometimes, um, they use some special prostheses or tools um, to, you can say, uh, to help them. Okay. Sometimes they teach the patient or the family to do some lifestyle changes. Okay, so of course, like when we will talk about different diseases, you would understand what I'm saying. Like uh, for example, if someone have some problem with the legs, so of course, like to um, make him so much like he can walk, or like maybe by the help of some prosthesis, or for example on a wheelchair, right? Someone who cannot speak, so um, like trying to bring back as much function as we can. So there are few terms, for example, okay, here it is written neuro rehabilitation, right? Because this one, like my first topic will be stroke. So see, a process whereby patients who suffer from impairment following neurological disease regain their former abilities. If full recovery is not possible, achieve their optimum physical, mental, social, and vocational ability. Okay, the point here is that you can see over here, Wikipedia says a complex medical process which aims to aid recovery from a nervous system injury or and to minimize or compensate for any functional alteration which is a result from this. Okay, this is very important thing to tell you about, like what is a impairment, what is a disability, what is a handicap. So as you can see, like what is an impairment? It is a loss of normal function of a part of the body. For example, someone have a paralysis of a leg, so that is a type of impairment that patient have. And if you will see, for example, here it is written disability. So what is disability? Disability is like when a person is not able to perform an activity in a normal way as like a normal person's can. So of course, like disability occurs as a result of impairment. Okay, so impairment is the loss of some function, whereas disability is the limitation which the person have as a result of that impairment. Okay, so that will be called as disability. So for example, a stroke patient who have impaired or paralysis of a leg and now he cannot walk properly will be, or no, he's not able to walk, is will be a disability. And what is handicap? Okay, handicap basically, we say when there are when any person with a disability, he cannot perform a specific role like a normal person. Okay, for example, uh, a person who was using a typewriter before or a keyboard, and he got or she got, sorry, rheumatoid arthritis, and so uh, he, like her joints get swollen, so she have that impairment. Now she cannot move her fingers properly, is basically a disability. And uh, she will be handicapped, of course, when she cannot use the keyboard at all, and she cannot work um, in that office or whatever, like so. uh, so simply you can say, we can say that a handicap is basically a term which is imposed by the society or by the people around them to use for a specific person to tell about that, this person is handicapped because he cannot do this thing, right? So this is the main difference between impairment, disability, and a handicap. Okay, so though it's a very interesting field, but uh, of course, like not much of the people, I think, they join these kind of programs. But like you can even do specialization in this one. So of course, in the hospitals, there are multidisciplinary teams who work together. For example, whenever there is a patient who had stroke, of course, like in the emergency department, the emergency medicine doctors deal them, and once the doctors have finished their work, then of course, like the next step is neurologist is going to see them, a nurse is going to see them, maybe a cardiologist is going to see them, then of course a speech therapist is going to see them, a rehabilitation guy is going to see them. So you can say it's a whole group, because as a result of stroke they have multiple problems. Maybe they have weakness of the leg, maybe they cannot speak, and maybe at the same time their bladder is not functioning properly, or maybe because they are bedridden they have pressure sores, or maybe they feel pain due to spastic muscles, or maybe they have like all this multiple problems, and of course like they will be depressed because now they cannot work properly, they cannot move properly. So maybe a psychiatrist is going to see them as well. So of course like it's a group of doctors who work together, and who like of course our aim is to let the person fit in any society, and bring back the functionality um, as much as we can, right? So this is the main aim. So simply you can say that like the persons who are physiatrists, what they do is they deal with the patients who have amputations, they deal with the patients who have stroke, who have TBI or traumatic brain injury, who have spinal cord problems, who have for example maybe rheumatoid arthritis or XY conditions. So all these things of course uh, they are um, they deal with. Okay, so now what I will be talking about is okay. I think one thing which is very important I should mention over here, which is called as ADLs and IADLs. Okay, ADLs and IADLs. Okay, what is ADLs? ADLs is activities of daily life, and what is IADLs? It is instrumental activities uh, of daily life. Okay, I think very important to understand this concept. Very, very, very important, and like to develop the basics to know about what is the importance of this thing. Okay, to talk about ADLs first of all, I would like to start like this way, that what we do daily. Okay, what we do daily um, um, for our self care, for grooming purposes, simply. So, simply, um, you can say we bath, right? And the other thing which we do is we dress up, okay, dressing. The other thing we do is we walk around, so mobility, okay. And other than that, what we do, other things are feeding, like we feed ourselves, and one of the things which we do is toileting. Okay, so see, these are some of the activities which we do every day and that are very, very, very important for our daily life, right? So what we do, we bath, of course. Bathing means, of course, like you take care of your teeth, you take care of your hairs, you take care of your nails, you take care of your personal hygiene, things like this. Then, of course, we dress up. Uh, we choose proper clothes, we wear them, and we dress independently, right? Like for example, now see if a patient who have rheumatoid arthritis, what will happen that they cannot button up their shirts, so of course like they cannot, you can say like they cannot dress up themselves. Mobility, so we walk from one place to another place, of course like if we, even if we have to go to bath, we have to get out from our bed, we have to go to the bathroom. And feeding, of course we uh, get the food from our plate, um, by whatever means, spoon or hands, we put it in our mouth, we chew it, so that is feeding, right? So feeding doesn't mean like we can cook or not, but feeding is like simply like you can eat, right? What the animals do, the for example monkeys, like you will give them banana, they can peel off the banana, they can put in their mouth, they can chew it, they can eat it up. And the last one is toileting, of course, like we go to the toilet, we can control our bowel, we can control our bladder, so that is very important. Okay, so these are all activities of daily life, right? And anyone who have some sort of disability, for example, of course they cannot do the activities of daily life, right? Or there will be some limitation, maybe they can do, but by some limitation, right? So now why this thing is important, because activities of daily life are very 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 important for anyone's independent survival. Okay, anyone, I'm using the word independent survival. So these are all the things which I think like everyone do, and um, like all these things, if they are not there or there is some limitation, of course either like you will be, there is some disability, right? We say that there is some disability to this person, that he cannot perform these duties on him or like by himself, right? So then comes the instrumental activities of daily life. For example, um, what are they? Okay, so first of all, like I will like to tell you about what is instrumental activities of daily life. These are all the activities that are basically more complex than these. Okay, number one, they are more complex than these, but like not just this thing. Okay, why they are complex? Because they need some thinking, some skills to organize yourself. For example, what are the independent activities of daily life? Okay, so the inactivities of daily life is, one of the thing is cleaning. Okay, now cleaning not yourself, brother, you can say housekeeping, cleaning your home. Like you need a brush, you need something to clean your home or the place where you're living in. One of the thing is laundry, of course you have to clean your clothes. One of the thing is managing money. Okay, one of the thing is wait, I must decrease the font size so that this must fit in up here. Okay, one of the thing is managing medications. Okay, one of the thing is cooking, of course like to feed yourself you must cook. One of the thing is you can say shopping also. That thing by the way comes in managing money, but it's okay, you can say. Then one of the thing is transportation. Now this transportation is different from the mobility, because transportation means like you are able to uh, drive, for example, or walk from one place to another place, like to go shopping to or do cooking. And nowadays they use one more thing that is called as using a smartphone, or you can say using the communication devices. Okay, so if you will pay a little attention, you would know that all these activities need some sort of thinking plus organization skills to manage these things, right? So of course like uh, these ADLs, they they are everyday tasks which everyone do. Okay, so a person need some physical activity to do these things. Okay. uh, and now the problem is anyone who have any condition, again I will take the name of stroke, spinal disorders, rheumatoid arthritis, sports injuries, amputation, whatever. See, they have either limitation of IDLs or limitation of ADLs. Okay. Think about a person who have Alzheimer's, dementia, a old guy, 75 years of age, and he's living alone, right? So of course, like, he cannot manage his money, he cannot manage his medications, he cannot cook, he cannot shop. uh, so how he will be surviving, right? But imagine a patient who has stroke, who cannot move his right hand, or like maybe right leg also, so he will be having limitation in mobility, even feeding. For example, he have dysphagia, right? Or maybe he cannot go to the toilet by himself. So of course many of these ADLs will be compromised as well. So simply, uh, in rehabilitation, what they do first of all is the assessment, right? Uh, so the assessment can be done by the patient himself, or the assessment can be done from the caregiver, right? Like, who will give a true picture about the patient, how much care he have to provide. Either they have to transport him from one place to another place, or XYZ, whatever is there, what is there. There are some special tools also available, or you can say index also available, which we can use. Like, one of the thing is the functional independence measure, FIM. Okay, things like this are there. So they can be used also to assess um, uh, the ADLs and IADLs. So of course we take history for that. And remember, all this ADLs and IADLs, they do matter for all of us, for everyone, right? Because uh, if we have this thing, we will be having, we can provide enough care to ourselves. And when we have this thing, instrumental activities of daily life, of course, like, you can live independently. So if you have all these things, of course you can live independently in the society, right? You can survive on yourself. So especially the old people, they have limitation of many of these things. Like older people, they cannot perform their all ADLs or ADLs, instrumental activities of daily life or activities of daily life. So because uh, they need some extent of help to perform such activities, like maybe with walking, maybe with feeding, maybe with dressing, maybe with toileting, maybe with transferring, whatever, or maybe to manage their finances, maybe to manage their transportation, maybe to shop or cook or communicate, things like this. So that's why all these things are important. And now the important thing is why I was talking about assessment. I was talking about assessment just because um, any patient who have um, limitation of ADLs or IDLs, we take history, we assess them, we see them, how much IADLs or ADLs they lost, and then they plan the rehabilitation. Doctors, they plan what can be done to bring as many as IADLs or ADLs back to the patient, so that the patient can survive either independently, or even if like he cannot survive independently, so that the caregiver have a little, you can, or he will be less dependent on the caregiver, right? So this is like all about activities of daily life and activities of instrumental activities of daily life. And simply, very important to understand, like, I think, uh, if you understand this thing, you would have a better idea what is the goal of rehabilitation, right? So um, next one, what I would like to go on is um, talking specifically about stroke, right? So we have done this thing, impairment, disability, and handicap thing, and um, after that, what is next is from stroke point of view. Now, and now I am talking more about uh, more from stroke point of view. Okay, um, okay. Basically, um, uh, whenever we are dealing with any person, even in rehabilitation, the thing goes same. You will take history, you will do examination, you will do some special tests. Okay, you will check the how much independent the person is, and then of course you can prescribe the right treatment. Either orthotist is needed, either speech therapist is needed. Okay, because remember, the impact of any disease uh, on any person is different. Okay, and that completely depends on the environment the person is living or the factors around the patient. Okay, so you can see that there are some general rules or general uh, things or treatments or techniques which are available, which can apply to almost all the persons who have that specific condition. Then there are some, uh, you can say, individual type of treatments which are available, which can be, um, you can say, um, uh, tuned up for that specific patient. Okay, so of course, like whenever you will go for a history, you will ask about the chief complaint, you will ask about uh, uh, what they think like what kind of disability they have, or what kind of independence, loss of independence they have. You will ask about the ADLs, you will ask about uh, later on the instrumental activities of daily life, you will ask about their profession, you will ask about their lifestyle, you will ask about all these things, of course. And in the examination, of course, what you will be doing, you are going to examine their musculoskeletal system, you are going to examine their neurological system. uh, Maybe you have to um, do some special type of test, like uh, ask them to walk, ask them to transfer, ask them to button up their shirts, ask them to comb their hairs, uh, anything like this, right? So of course, like by that way, uh, you can assess like what is the condition of the patient. So history is very simple. Like they ask simple questions like, are you able to walk without help from anyone, or do you need any assistive type of equipment like crutches or braces, or for example, do you use a wheelchair? Okay, uh, or if you want to ask about IADLs, do you go to visit your family, your friends? Do you go to restaurants? Do you go for shopping malls? Uh, do you fall? If you fall, how often you fall? Can you drive, or can you climb stairs, for example, or can you get up from your bed unaided, or you need some help, or can you bath unaided? So all these questions, can you eat yourself? Can you cut the meat? Can you chew up? Uh, all these things, of course, like can be asked, right? So of course, like history examination is like the part of almost all the medical field, and should be asked. Uh, we can also ask about their aims, like what do you want to do? Like either you want to go back or join back your previous job, or what you were doing. Okay, um, just to check, like either they want some specific type of skill back so that they can earn money or they can survive. Okay, so of course, like then what you can say, the specific type of treatment can be decided. So that's like, I think, pretty much about uh, what you can say, the basics. Okay, like how to start with rehabilitation. Yeah, and depending on, like, for example, as I told you, there is cancer rehabilitation also. There is what you say, pulmonary rehabilitation also. Like the patients who have stroke, who have, sorry, COPD, for example, we refer them for pulmonary rehabilitation. Okay, so of course, like, pulmonary rehabilitation will be different from neurological rehabilitation, because there is a, like, the function is, the system is different, the things are different, right? So rest, of course, like, you know how to do examination, you have done that. Okay, and if you will correlate the normal history taking, the normal examination with this thing, that is almost the same. Okay, just especially like, the only difference, in physical examination is, like, there are special tests. You can check their balance, you can check, they can transfer standing balance, eating skills, dressing skills, personal hygiene skills, ambulation, things like this. You can check in the patient, and then you can decide, like, what can be done for that specific patient. So now, let's start stroke. Actually, all my previous classes, like, which I take on rehabilitation for the previous sessions, of course, like, what I used to do is, like, I teach them more stroke and less, you can say, less about what are the techniques which are available to rehabilitate. So, uh, okay, as because, our first thing which we are going to study is stroke. You can see over here, neuroplasticity. You know, a brain is such a marvelous type of organ, that it has the capability to reorganize by forming new neural connection throughout life. So that is called as plasticity. uh, if you know what is plastic is such a thing, we can mold it from one shape to another shape. So what happens in brain, for example, anyone who have some brain damage as a result of anything, for example, stroke, what happens, like, by proper training, you can develop new neural connections, and that basically work very good. Okay, so let's start with stroke, and then we are going to discuss, like, the what you can say, um, modalities which are available. Okay, which can be used for stroke rehabilitation in the patient who have this thing. So, uh, as we know, what is stroke? Basically, um, stroke is defined as uh, a sudden neurological impairment, and it results from interruption in the blood supply to some um, specific part of the brain tissue. So, what happens that, whenever anyone have stroke, so what happens is basically, they quickly have some sort of weakness, right? They present with some physical weakness or numbness on of any part of the face, arm, legs. Okay, maybe they have difficulty in speaking, difficulty in walking, difficulty in balance, or sometimes, after stroke, the patient become unconscious, they faint. Okay, so um, now, the important thing to mention over here is, um, stroke is very, very, very common. You can see over here, some things are given, like, 15 million stroke cases, 5 million die, 5 million permanently disabled. So a very common cause of disability. So basically, there is one more thing called as TIA. So what is TIA? TIA is transient ischemic attack. So any patient who have TIA, basically their symptoms and signs, it lasts for less than 24 hours. Okay, so stroke is when someone have these losses for more than 24 hours. Okay, so we call it as stroke, this patient, or if you found any, um, you can say, radiological evidence of a stroke. Okay, uh, so um, what happens, like, only in America, the American Heart Association estimates that there is around 780,000 strokes annually. Okay, and out of that 780,000, they say that around 600,000 are basically new cases, whereas 180,000 out of that are recurrent cases. You can say person who had stroke and they had stroke again. So of course, uh, a stroke is very important, very common. If you go to neurology ward, you are going to find a lot of patients with stroke. So that is what you can say about uh, the epidemiology, as we know that. Okay, this one. These are the five basic principles governing neuroplasticity. Body parts compete for brain representation. Now, um, if you had done neuroanatomy carefully, you would know that our hands have a very big representation in our brain, whereas our foot or legs, they don't have much representation. Our facial representation on the brain is too much. So when you use anything more and more skillfully, your brain give more area to that. Okay, so uh, that's why it is written dependent plus plasticity is more than experience dependent plasticity. So there is a need for the brain to use experience to initiate new synaptic connection between neurons. Okay, so why we are studying this thing, of course, all these things will come, and you would understand like how stroke makes like how rehabilitation makes the condition better. Number two is the ipsilateral and contralateral hemisphere can contribute to motor control. So, see, if one hemisphere is damaged, the intact hemisphere may take over some of its functions, right? So, like these are, you can say, all the hopes which I'm telling you, which can be used or which are there by which the person who have stroke they regain their function, they go back maybe after months or years or weeks, whatever, back to their society, back to their daily life. Of course, like if not fully recovered, then you can say much better, much recovered. And principle number three, sensory stimulation enhances plasticity. So when we give sensory stimulation, it enhances the sensory representation of the body part. So this thing, then you can see over here principle number four, reduction of inhibition enhances plasticity. So see, remove factors that make the patient less motivated and sleepy. Treat post-stroke depression, but do not use drugs that induce drowsiness, right? Because reduction of when we reduce the inhibition, plasticity is more and more brain can make new neuron connections and more functions can be brought back. uh, Pharmacological agents can enhance plasticity. So in ischemic strokes to reduce infarct site and promote repair and improve final functional outcome, or simply to improve neurological recovery after stroke. So uh, let's talk about quickly talk about we had done stroke in neurology, but let's quickly revise that as we know that there are many factors which increase the stroke. For example, age. um, Males have more stroke than females. uh, then there like people who have family history of strokes. Hypertension is one of them, like heart diseases, uh, diabetes, cigarette smoking, all these things, or too much use of alcohol, hyperlipidemias. All these are modifiable risk factors of stroke. So now, if I will talk about the type of the strokes, okay. So basically, there are two types. Like grossly, we divide it into hemorrhagic as well as non-hemorrhagic or ischemic, right? So hemorrhagic strokes account for around 50% of all strokes, whereas um, ischemic strokes they are around 85% of the strokes. There is one more thing called as subarachnoid hemorrhage, right? So subarachnoid hemorrhage is a type of hemorrhagic stroke. So you can say like out of 15% of hemorrhagic stroke, basically 10% are intracerebral like which we also call as hypertensive hemorrhage, whereas 5% are subarachnoid, or which we can say they occur due to rupture of some aneurysm. Okay, so now uh, uh, the 85% of the ischemic strokes which are there, out of them there can be large vessel, which is more common, 40%. Then there is small vessel, around 20%, and then there is cerebral embolism, around 20%. So these are, you can say, and there are some other very rare, like less common causes like vasculitis and things like this, which can also cause stroke. So simply, whenever someone have stroke, how they present with weakness, they present with sensory problems, they present with aphasia, they present with coordination problems, they present with balance problems, they present with multiple problems depending on what area of the brain is gone. So, uh, simply, what we are, if like, I don't know how much you remember, but stroke medicine itself is a very big field, and you must know what is internal carotid artery, what is external carotid artery, what is the presentation of the patient in MCA, middle cerebral artery stroke, ACA, anterior cerebral artery stroke, PCA, posterior cerebral artery stroke. What are the signs and symptoms of vertebrobasilar uh, system stroke? What is lateral medullary syndrome? What is many are there, right? So uh, I think like you must be familiar with these things, right? Because and then there is lacunar strokes as well, which can be pure motor, pure sensory, dysarthria, or something we call it as ataxia and leg paralysis and all these things. Okay, so I think like you must be you must make yourself familiar with these things, because these are very important to understand uh, what is stroke, right? Okay. um, Again, like I'm just revising that thing, because in the next lecture I will be talking about uh, the modalities which are available to treat or to rehabilitate stroke. So the story goes like this way: like anyone who has stroke, what happens is they are brought to the hospitals. As soon as we see any stroke patient, the first thing we have to uh, see is like either it's a hemorrhagic stroke or either it's a ischemic stroke. So we go for a head CT scan, and on CT scan, of course, we can simply see either there is a hemorrhage or there is no hemorrhage. Why? Because the treatment is completely different. Okay, the treatment is completely different depending like either the hemorrhage is present or not. Because when there is no hemorrhage, of course, we deal it like a ischemic stroke. We give them, for example, clot busters like TPA, tissue plasminogen activators. Okay, so that thing is that given. But if it is hemorrhagic stroke, of course, uh, we basically control their blood pressure, and also this is the immediate management. We run a lot of other investigations like ECG, carotid ultrasound, angiography, things like this, simply to locate the stroke or to see like from where, like how the stroke occurs, right? So of course, we stabilize the patient in emergency. We do CT scan. If there is seizures, we control that. We check their blood sugar levels. We check their uh, blood pressure if it's a hemorrhagic stroke, and we manage the blood pressure if it is too high. Uh, we manage the seizures if they are there. Okay, all these things are managed. And if it's a ischemic stroke, we go for TPA, tissue plasminogen activator. And of course, we like in ischemic stroke, we put the patient on heparin, or some antiplatelet therapy like aspirin, clopidogrel, and things like this. And uh, that is also simply, but the treatment of subarachnoid hemorrhage is a little different, because what we put them on calcium channel blocker nimodipine to decrease the risk of any cerebral spasm. So all these things are done to the patient of stroke, so that uh, like there should be either no re-stroke, or either there should be least damage to the patient. And of course, like there is a lot of investigations and there is a lot of other things which can be done for these patients, but we had done that thing in our neurology lecture, so I'm not going to talk about that. So thank you so much, guys, for listening. And in the next lecture, what I will be talking about is about stroke rehabilitation directly. See you in the next lecture.